Y'all, today's guest, I'm clearly a fan of University of Tennessee, Knoxville, their SLP program and the great work that they're doing. But I specifically asked Maggie Wheeler and Briana Klar, today's guest, to come on and to talk about how they went about treating pediatric feeding and swallowing disorders in their university clinic. Because here's the catch. If we want to grow strong clinicians in an area that is so underserved, because in all actuality, pediatric feeding disorders, the prevalence is so high, but we just don't have enough clinicians to serve them. But if we want to do this and we want to do this well, then we need to look to the universities and the clinical educators that are doing this amazingly well and replicate those programs in other university clinics, which I am incredibly aware is easier said than done. But this is a template. This is a starting point. So I hope you enjoy the episode. I hope that no more snow comes this way until at least Christmas, because we had a snowstorm on Friday and the kids were home, and we had one swing by on Sunday. They announced it Sunday, and then we've been snowed in. So we've missed 4 days of school in the last week. To all of the other working moms, you get it. And the working daddies, you get it. So I'm going to go focus on rest after I help that child finish shoveling. I'm pretty sure he's put a dent in the snow shovel, and I hope y'all enjoyed the podcast episode. So toodaloos, y'all. Enjoy. I am tickled pink because University of Tennessee SLPs are back. And this time, the lovely Miss Maggie brought her sweet friend, the lovely Miss Briana, who has had zero sleep because she's new mommy. I'm like, I don't miss those days, but I miss some of the smells. But yeah, accurate. But we're back because not only did they have this phenomenal early intervention program, but this clinic is one of the few clinics in our nation that actually evaluates and treats pediatric feeding and swallowing disorders in the university clinic. So, humans, if you were listening and you were looking to go this route with your career, may I recommend applying to this graduate program, because that's very rare and you're going to learn a lot and the women are brilliant. But also professionally, if you work in a university, please dog ear save this episode so that you can make a pitch to implement this in your setting, because PFD is going to grow because we're saving babies that we weren't saving. And we need to do best by our future generation of SLPs and the future of our society, and create opportunities for training with evidence-based practice. Because if we don't teach them, they're going to go on Instagram and watch somebody booty shake and feed them a French fry. So let's teach with compassion and eloquence and evidence. So on that note, hi, welcome. Maggie, why don't you introduce yourself first and kind of get us started, and then we'll segue over.
Okay, sure. So I'm Maggie Wheeler. Hi again. It's so great to be back. So we talked last time a lot about our EI clinic, working with my lovely autistic babies. And as many of you know, along with having language delays, several of those kiddos are also going to have some feeding issues.
Yep.
So my side of the spectrum here in our program, I tend to deal a lot more with like the sensory aversive feeding kiddos. Again, I have 3 evals coming up that are all current patients of mine who are finally ready to tackle feeding because they are just not building that food repertoire up. So that's kind of how I fit into the feeding program here. I don't say it's my main area by all means. I leave that to Briana and her knowledge, but we kind of divide and conquer between the two of us. And I come from 12, 14 years ago at grad school, never having a pediatric feeding course, always thinking it was interesting, but it wasn't a thing in our clinic. I went through our program here. And so in that 12 to 14 years, I started to have a greater interest. And I really think for me, working with autistic kids, it made a lot of sense to start getting some continuing education and some mentoring in pediatric feeding. But also I have 2 littles, and I loved the transition from bottle to solids. And I thought it was so interesting. And I was reading and researching, and I was like, man, I think we can also kind of cut off some of this intervention if we help support families with how do we make that transition happen? How do we help our kids? So I think that's really kind of how I got even more interested in the idea of working with feeding disorder and in the pediatric population was that transition as a mom and figuring out like, this is scary. Like, I get why so many families have struggle with moving to solids and stuff. It's definitely scary, even with the backgrounds that we have. So that's kind of how I landed here. And I think I'm still learning and growing in this area of the field, just like probably so many of us, and love Michelle's podcast and have been to some of her ASHA presentations and all that good stuff. So I'm still definitely an active learner in the PFD world.
Dude, I think I learned something, and then I'm like, okay, I'm feeling all right. I got this week. And then like a new publication drops, and I'm like, I'm a freaking idiot. Like, what do we?
Why was I ever doing that?
And that's why we're life learners.
I didn't know, and now we're going to do it better. But
yeah. Well, I tell my students, I'm like, it's still like a baby in our field, like there's not the research. Like, it's just this infant that just really became part of our field. And so we're all just navigating it together the best we can.
Okay. So I have a thought, but I'll come back to it because I don't want to go too far down that new publication rabbit hole. But Briana, hi. Wait, tell us about the baby.
He's so precious. His name is Theo. And I think when you were here at Soul Adler, I was trying to decide on that middle name, and we did decide on Leonidas. So we have a little Theo Leo.
Theo. Okay, so the lady I recorded yesterday has a Theo, and she's in Australia. And we got sidetracked talking about which way the toilets spin, because they do in fact spin in the opposite direction, which is spectacular. And she calls him Theo too. And Bear was sitting right there when I was recording it, and he goes, "The world needs more bears." I was like, as the mother bear, debatable. Theo is perfect. Yeah. Well, how did you come to be in a university? Because it's my understanding from when I was there touring that you do more like the dysphagia side for the people.
Yes. So let's see. So I'm trying to think how to like paraphrase everything. But I initially, like after grad school, was working in the schools. Mm-hmm. And I had a lot of AAC users on my caseload that had sensory differences. And I was really struggling with joint engagement and trying to figure out, how do I get this kid engaged with me? And so then I started down that rabbit hole of sensory strategies in my sessions. Yeah. And going down that rabbit hole, I realized that I myself was undiagnosed neurodivergent and had diagnosed now.
There
it is. Motherhood will do that to you.
Yes, ma'am.
But let's see. And so it made me reflect on my own childhood. And one of the biggest struggles that my family had with me was meal times. And because of those sensory differences, and I became very overwhelmed with like the smell of foods and the taste of certain foods. And so I just really relate to these PFD kids in that sense. I didn't need feeding therapy per se, probably could have benefited from it, but and so then, I don't know, I just felt like this passion was just lit in me that I wanted to work with these kids. And so I made the switch to schools, to a pediatric outpatient clinic where I got my hands-on experience working with PFD. And then from there, when this position came available, I kind of always thought I would eventually become a clinical supervisor, just because I thoroughly enjoy mentoring others. Like, it brings me so much joy. And so I always thought like clinical supervision would just be this perfect combination of speech pathology and feeding therapy and also mentoring and passing on that knowledge. And so I always thought it would come later in my life. But when it came available, I was like, you know what? The worst they could tell me is no. And so
yes,
I just
take the shot.
It's a shot, and I took it, and I got the job offer. And so now I'm here, and it feels like a crazy whirlwind of events, and I'm now speaking with you on this podcast.
Also, I love how you have your fidgets. I have my fidgets. Everybody, Maggie, where are yours? Yes.
Yeah.
Hair ties. I love playing with my hair ties. Yes. Okay, so 2 thoughts. One, ladies and gents and humans listening, this is not evidence-based, but I finished a really, really ridiculously good book, and it was called Love Rebooted, and it's on Audible. One, it's spicy, super spicy. Do not listen to it with children in the room because the author, she knows what she's talking about. But she's actually an autistic disabled author, and she wrote this character and gives lived experiences. But in the book, it's about 2 techie computer engineer people and a love story. But she has this whole scene where she engages with wasabi, thinking it's not wasabi. But the way she describes her eating habits and patterns, it's just I learned that additional layer and perspective through this super hot, trashy romance novel. So I thought y'all might also enjoy Love Rebooted on Audible. It was free. But I also love it's an autistic disabled author. So yeah, but the new research that just came out, Amy Delaney just led a publication on textures for neurodevelopmental progression. And I love because it's new, just published within the last two, maybe 3 months. But what she was talking about is we have to know typical neurodevelopmental norms for texture preferences so that when they're going down to the next step to extrapolate the data, we'll be able to pick out and make predictions for individuals that have Down syndrome, for our congenital heart defect. And then they want to look at the autistic population because there are not IDSI level viscosity, but textures like mash puree, and the language that they chose was more user friendly for a caregiver, which I appreciated because if the way she described it, I was like, I can talk to a mom using those terms, right? And they did loop it into IDSI in the body of the paper, but it was wicked freaking great. And it just came out. And I was like, this is fundamentally changing how we practice because now we have neurodevelopmental norms. And then in the next 2 years, we expect to have more data, but we can talk to these caregivers and say, hey, this is where you're at right now. And this is great. We might not need therapy right now, but let's see how this progresses. And you can do episodes of care, episodic care, however you say those phrases. But did you know that came out? If I didn't know Amy, I wouldn't have known it came out. Is that not crazy? How quickly it's in our infancy.
It's been cool her doing a lot of the getting the better norms and stuff for those infants and toddlers transitioning. I actually, the timeline worked out where she was recruiting and I did from a distance, of course. I recorded my daughter and sent her. So my daughter is going to be, one of those kids. And it was, she was, I guess, 10 months old, 9 months old or something like that. And I was sending, pictures of what she had for dinner and how she, took videos of her. And I'm like, this is so cool. You being able to contribute and the timeline, lining up with what Amy's studying is just, she's just doing some really cool work.
Yes. But that's the continuum. This is the, we need the research and the research to be funded for continuity so that we can put this into practice and teach the next generation so that to go back to your clinical supervision, Briana, and then let it go forward. That was
awesome.
Total pivot in the conversation, but amazing. So folks, huzzah for ongoing research and also why we guinea pig our children as faculty and SLPs so that we can help.
Yeah. Briana are constantly like taking videos of our kids. So when she goes and teaches our dysphagia course, I'm like, do you need any new videos? Like what age ranges are you looking for? Cause like our little guinea pig children have just like file after file of them eating. So, I'll ask permission one day, but for now they're fine.
Okay. All right. So how in the blue blazes did y'all pull this off? How did y'all get feeding in your university clinic? Cause that's an act of God.
But we were talking about it, and it's funny because it predated me, even as a student. I was no longer a student, but not back as a faculty yet. So I kind of had to do a little bit of thinking and digging to find out a little bit more about how we landed here. And it honestly, it doesn't seem like the most intentional thing. It's worked out beautifully, but it's great. We essentially Bree's predecessor had a lot of extensive pediatric feeding in her caseload and history. And so when she came on, we really try to house faculty who have specialty areas, right? To make sure that we're covering, all of those for our students and just have those mentors who are really, truly experts in their field. And we're really, really lucky to have a pretty large clinical faculty to where we have a voice expert and we have an adult dysphagia expert and we have a huge faculty. We really do. And it's amazing. And so we had an individual come on and she had extensive pediatric feeding, especially the medical side of things. And so with that came referrals and came current caseload that just, already knew her in the community. And so, a couple of years ago when she decided to move on to something else, we obviously were looking for someone who had that PFD background to continue seeing those patients, to keep that referral line open. And we're lucky to have, Briana, who had that outpatient experience to bring in. And so it just has become part of, our clinic here. And, so she initially, had the caseload and then again, a few pediatricians or I think there was a couple like physiatrists in the area who like really worked well and knew her really well. And then just by, good work and continued communication and interdisciplinary practice, we've kept those referral lines open. Our early intervention system, before, they're always looking for new vendors and things like that. And so being able to say like, we're, now a feeding vendor because, not really anyone else on their caseloads was doing pediatric feeding. And so once she left, Briana came in as our primary person. I started to take a little bit and mine really mostly started as, again, kids on my caseload I'm seeing for language or for AAC support or something. And the family brings up the feeding and we talk about it. And then I, typically I'll do a feeding evaluation during like one of their session times essentially. And then either pick them up myself if I have room or maybe then share them with Briana. And so we have a collaboration there where she's really serving as the feeding therapist and I'm still remaining in the speech, side of things for that kiddo. And they're coming twice a week now instead of just once a week. But that's really how it evolved. It just kind of happened. I mean, there's a need. I mean, I'm sure just like across, various parts of the country, we have, we hear some unfortunate stories about feeding therapies and being force fed and things like that. And so we're hoping to keep turning that around and to hopefully be educating students to go out and to do what we believe to be best evidence-based practice, whether they remain in the area in East Tennessee or otherwise.
Yes, I think Dr. Aaron Kleiner, Dr. Memory Goza, and there was a third person, and forgive me, I don't remember who, but they did one of the invited talks last year where they actually went through and they did the data on like how many university clinics have the actual capacity on their clinic campus. And it was not that many. I set it up at Francis Marion University, but when I left, because I was driving an hour and a half one way to work, and when I left FMU, the PFD side closed, but they kept the adult side. Dr. Michelle Norman was there for the adults, but like there was nobody else that could take it over. And then I set it up at James Madison, but when I left JMU, it also like it stopped because there's no you have to find the faculty and you have to have the funds to keep the faculty, because that's a problem. But how do you keep it going? I want to know what testing protocols are you using? Like what screening tools? Like I want all of the details. Like how is it funded? Like I have so many questions and I don't know where to start. Briana, I'm sorry. I'm just very excited.
That's all good. Let's see. For testing protocols, I use the feeding flock a lot with the students when we're doing like the evaluations. I love them. And
I just totally screwed up. I told one of the young ladies that's in her CF that I'm mentoring, I was like, just go on Feeding Flock and pick the tool that matches. And I was kind of listening to her because I'm just like, I'm not her direct CF supervisor. I'm just helping from the sidelines. Bless her heart. I got sidetracked with the patient, came back 90 minutes later. I think she administered all of them, like all of the feeding to the same family. And I was like, oh, Snikes. I meant one, honey, just one. But like, I failed. But yes, but like, do you have a one that you lean more towards, or?
Oh my goodness. I'm sorry. I'm trying to pull things to the forward of my brain.
No, it's okay. Like I know they have like the little bitty baby ones, and then they have the ones for like older kids. Is there
yeah. Like the Pedi Eat we do most of the time.
The Pedi Eat. Thank you, Maggie.
Yeah,
the Pedi Eat is probably going to be that one that we use most. Because most of our referrals are from TIS, to be honest. And so when we're getting the kids, they're over that early intervention system.
Okay. Yes. Yep. Cool.
Yeah.
Cool.
And so most of them I find are over that 6-month range and are either being seen in our EI clinic upstairs or have Maggie as one of their therapists on their team as well. So I want to say mostly they're about 2 years old.
Yes. So I have changed how I ask the questions according to the 4 domains.
Yeah.
Especially how I ask the nutrition questions. So folks, recapture pediatric feeding disorder. You have the medical domain, feeding skill, like how they consume the food, and nutrition, what types of food they're eating, in the psychosocial is the child's relationship with the food, the caregiver's relationship with the child, with the relationship with the food. And that is like a 30-second synopsis. But I used to ask a lot of questions about like specifically what foods they accept, and give me a crash course, give me a 2-week diet. But then I saw all the trauma that it was triggering for these caregivers to have to recapture that, and then the sense of shame that they were bringing. So now I'm very careful, but how I ask those questions. But like, how are y'all asking? And this is just general curiosity about the nutrition domain specifically, and then guiding the students in that one.
We have a food preference checklist that I have parents fill out, and I just have them like circle foods that the child accepts like 50% of the time when it's offered to them.
That's cool.
And then it's broken up into the different categories of food. And I like it because it's very visual for me. Like I could really see like if a certain group of food is like completely missing or is lacking. And then from there, I ask more specifics on like say if the family circled like carrots, I'm going to ask like, how are you serving those carrots? Is it
that's a weird one.
That's a weird one, right? Like carrots can be multiple textures. And so once I have it in front of me, I'm able to ask more of like those type of questions to kind of get an idea of what the textures are like. And I go over it with the students too. And we kind of like treat it as like, let's see if we can figure out a pattern to the types of food that the kid is eating, the textures that the kid is eating, how difficult those textures are. Are they easy foods to eat? Or is this kid's like main proteins like yogurt? Or are they accepting any form of meat? And then like the types of vegetables, how is that being presented to them? Is it like, on a plate and it's like just that vegetable by itself? Or is parents incorporating it in some type of smoothing and then like circling that vegetable? So
yeah, but see raw, the shapes. You said carrots, and I'm thinking I have eaten a lot of carrot chips lately because that goes over more preferred than like the little carrot nubs.
Yeah.
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 It's hocus pocus. It sounds like the dead man's toe. That's what I think of when I think of the carrot nub.
Like the little baby
and
carrot.
I feel like if I have, especially if I have a diagnosed, autistic kiddo, I usually present the checklist to the family and say something similar to like, I don't expect little Charlie to always want to play with every single kind of toy that's out there. He has his specific interests. And I'm going to say the same thing about food. I'm not going to expect him to always eat every single food presented. Do we like everything presented to us? No, that's totally fine. So, I want to see a little bit of food in each of these categories is what I'm hoping to get by the end of, feeding therapy or whatever. And just laying that foundation, just because we're not trying to cram a neurodiverse kiddo into a box of, well, you have to like Brussels sprouts. If you don't like Brussels sprouts, then you're not going to be okay in life, So same thing, if you don't like to do puzzles and, I'm going to force you to do a puzzle because you have to be able to do puzzles to function in life. Like, that's not true. I'm not going to force you to play in a specific way. Just like I'm not going to force you to have to like every single food that I ever present to you. Can we nicely and politely get rid of it? Sure. Let's not throw it across the room, but but I think just reminding them like what your expectations are. Like, we don't like everything and that's okay. You don't have to have your kid like everything either. So don't, just kind of take that pressure off when you give it to them and make sure they know I'm not like judging what the kid eats or doesn't eat.
Yes. Well, obviously you have had a friend throw a plate of food because I know I have. I feel like that's
my own kids. What are you talking about? It's my kids. It's them.
We've had, when we first moved here, there was some like creative culinary creations out of the kitchen because it was just like, we just moved. I'm throwing stuff together. Like, I think we might have just lived off Chick-fil-A for like, honestly, way longer than we should have setting up a new house. But like, I remember one time we sat down and Bear was like, Mom, can you just cook the good stuff again? And I was like, what's the good stuff? Shepherd's pie. All the kid wanted was a shepherd's pie, but like, he couldn't remember. He's like, it's the sheep pie, the sheeps. And I was like, what's he talking about? But like, we got there. But I use that as an example because we have our comfort foods. We have our foods that we're going to gravitate towards because of emotions, stress, tension. And that pulls in that psychosocial piece. But what I also find is that when we're asking these questions, how hidden layers of trauma there could be underneath, because we don't know if the caregivers have an eating disorder. We don't know if the graduate students we're supervising, they may not have disclosed whether or not they have an eating disorder. And so there's all of these layers of nuance to teaching how to ask the questions, not just from nutrition, but for psychosocial. So how do y'all handle that? The eyebrows. I love the eyebrows.
It's like,
I'm like, no, but like this is, I think about these things.
That's a big question. Yeah. I mean, I've already had students. They're not children. They're students. They're my speech babies. I had even something as simple as having one who had an allergy and I hadn't encountered that yet. And I was like, oh gosh, we are playing with peanut butter with this patient. And I have not processed what to do with a student who has an allergy. Okay. Like, thanks for disclosing that. It has things like that where I feel like I need to be a little bit more, outright about like, hey, tell me if anything feels uncomfortable or like it's okay. We don't have to like everything, because there's been times too where Briana and I have left and I'm like, I don't want to eat what that family brought in for that kid either. Like, oh gosh, and I know the students might feel that way too, because I do encourage them. I'm like, we're playing with the food along with them. Of course, we're trying to model bites and things like that. So if there's anything you're uncomfortable with, or if that feels weird, like, let's talk about that. It can feel silly, but, usually the better, the messier you are, the better the feeding therapy is going, I feel like. And so, having some more of those conversations, but I think they're all just really curious right now. Like, feeding is really something that a lot of the students come in. And so I think I don't have to do as much work on the front end. I feel like they're coming to us being like, can I observe a feeding eval? Like, can I do this? I really want to get Like they're wanting that experience. And so thankfully, it seems like a lot of them are really good about kind of just being upfront with us and looping us in on any of those needs. I know food scarcity is something like in our area that we see a lot about, and Briana and I have talked about ways to kind of tackle. And we do go as far as to go shopping at the grocery store by ourselves and not get reimbursed and bring in things for our patients because we don't want to ask too much of the families. But we've talked about how, it'd be great if we could, find collaboration with, our College of Social Work or the food pantry on campus or different ways that we can connect to make that carryover easier at home too, because that's something we always are concerned about. We want the families to bring things in, but also in order to try and reach the things that the kiddo isn't trying yet. I get it if the family doesn't want to go buy a crown of broccoli because that's just going to get wasted, So that's kind of a battle that we're constantly tackling because we are university funded. So we're billing insurance for the sessions, but we don't have a lot of wiggle room for just keeping our pantry, overflowing or, just having every single thing at hand that maybe some larger outpatient clinics or something might have a bigger option there that we just don't. So there are things where we want to continue to bridge those gaps too from clinic to home.
But those are social determinants of health. That's a real life scenario where, and let's be honest, with SNAP and WIC getting ready to be cut further, that it's for our families that are at risk, it could be worse.
Mm-hmm. Yeah. And I've shared that too. Go ahead, Briana. Sorry.
Oh, just like when we come in and do feeding therapy, like most of our families, they're bringing in the food. And that way we know like what kind of get an insight of like, what is the family's like food like at home. Yeah. And that way the carryover is better as well. But when you know that the family that's coming in has a lower socioeconomic status and their kid may or may not eat that food within that session. And I always give them the option, like, do you want me to pack this up? And that way you can take it home. Somebody else can eat this food. Sometimes they're like, no, just throw it away. But oftentimes they're like, yeah, let's like pack it all up to go. And like bring it.
Yeah. I keep my aluminum foil and my like extra Gladware, the little Glad to go. They make me think of Golden Girls. I have no idea why there's an association between Gladware and the Golden Girls, but that's what I see is them cleaning up spaghetti. But I will pack it up because you don't know. Now, Briana, can I ask you a personal question about and if you tell me no and debugger, I'll remove this. But how do with the neurodivergence identification? How do you honor and acknowledge the authenticness for the tiny humans that you're working with, but also what if you see it in one of your students? And like they could have a sensory nightmare about trying a new food because I've seen that and been like, honey, don't worry about it. I got this.
It's okay. When it comes to the students, like Maggie was saying, like, I just feel like they're so open with us. And I don't know if it's because like we're approachable or what, but they just wanted to, since they know like we're working in pediatric feeding and there's food involved. And I'm pretty open about things that make me like sensitive. Like some foods still, like I get really nauseous at the smell of them. Like don't bring canned green beans around me. Like I might puke. But I tell the students stuff like that. And so I feel like they are more open to tell me when they're having maybe some sensory sensitivities to a certain food. Yeah. But one of the things that I do as part of like my clinic when they're assigned to me as like a student is I do weekly group meetings. And so one of those meetings, we go over the sensational brain sensory checklists. And in order to like know, because I feel like in order to really like know your patients and kind of like what they are going through, you have to be very self-aware of yourself and your own like sensory preferences, I should say. And so one of the just like group meetings that I have with just like a few of the students at a time. But we kind of go over that together, and I'm open about like things that I get overwhelmed about, and then they're open to talking about it too. And it's just an open dialogue essentially.
Ah, that goes back to, are we creating safe spaces for the students? And I see that as, it's not even just within like the department, because your departments typically have two houses within one. You have the academic side and then the clinic side. And if there's not as much segue over between and it's truly compartmentalized, you can have different flavors of welcomeness within. But one of the things I remember sticking out when we were there. So y'all, so backtrack. I met these lovely ladies through the Saul Adler, which is a conference that y'all have every spring, and you invite a speaker to come, and it's named after Dr. Adler, who is one of the founders and pillars in your program. I like how I'm pitching this as if you don't know this information, but yes, but folks, sign up and go, because wait, in the spring, who do y'all have coming?
We have Rachel Langley from Stepping Into AAC, March 27th.
Yes. It is such a great conference. Y'all had so many beautiful people, and it's counts for CEUs, so you can go to this. But I remember when we were doing the tour, y'all were talking about how the peds feeding and dysphagia class, y'all swing shift it. Like there's multiple faculty. So can you talk about how you pull that in? Because that bridges the academic and the clinic.
Mm-hmm. So for the dysphagia class in the spring that we offer, it's split up into 3 different segments. So Dr. Paik, she teaches that first 7 lectures, and she covers just the typical anatomy and physiology of a swallow. And then her main like research focus is adult neurogenic disorders. Cool. And so she covers a bit of that. And then my colleague, Angie Orr, who is the adult dysphagia clinical instructor here, she covers adult swallowing disorders. And then I come in and lecture on pediatric feeding and swallowing disorders. So I do typical feeding development, disorders, evaluation, and treatment as part of just our regular dysphagia class. So it's pretty equal in division between like the adult side and in the pediatric feeding side.
That's amazing. Also, I got to be honest, I hate teaching typical dysphagia or typical swallowing acquisition from like in utero up, because I'm like, I know. I'm like, that's so boring. Just read the book and memorize it. Like, I don't want to talk. I want to talk about like, hey, you're covered head to toe in eczema and you have this asthma. So like, let's talk about your like potential food allergies and what does EOE look like for you. But like, that's where I want to go, because that you got to pull that information in to get them over.
Yeah.
Do you feel like having that trio really sets them for success with like with clinical application?
I think so. Yeah, I feel like the students are pretty good about transferring over what they learned in class and then applying it into the clinic here. Because in that course, like I discuss a lot about like all the different disorders that can affect pediatric feeding and swallowing, and how a lot of them, we may not be that person that's treating that. Like we need to make that referral somewhere else. And that medical professional is one that's going to probably make that positive impact on that kid's feeding and swallowing. You know, if they have an allergy that's been unidentified, once that's removed from their diet, their feeding is probably going to improve. It's nothing that we necessarily did. It's just having that kind of like that detective mindset in mind of like trying to figure out who does this kid need that might not be me. And so when we're doing our evaluations in clinic, like, or just seeing our kids that are already maybe established in therapy, like we're always like discussing and keeping in mind, like, okay, I'm seeing this kid is having like vertical chewing patterns and it's like open mouth breathing. we probably need to look at to see what those tonsils are like, because maybe they're not having issues with chewing because there's a skill deficit. Maybe they just can't breathe and need to have like an ENT referral. So I think they are pretty observant too. And sometimes they actually pick up on something that I may have missed because I was looking at one aspect of that patient and they were able to focus on another thing. And so we're just collaborating together and talking about it openly and seeing like, okay, who does this kid need that might not be us here in our clinic?
I love it when the speech babies catch something, because I'm like, yes, you learned. And that's, yes. But so how do you help them? Like, how do you encourage their learning curve so that, to go back to what Maggie said, your clinic bills. So while it's teaching, you still have to show progress and growth. Otherwise, insurance will say, thank you, no, thank you. And we don't want that because it's going to be harder to prove that we're needed. So what do y'all do? I know you mentioned the weekly meetings, but like what other aspects are, and the setup of the class, but what other aspects do y'all do to set them for success?
I would say that before and after every session, we're talking it out. And then even in like the session, if like they're witnessing me talking to the parents about those concerns too. And so I just feel like it's just open conversations between myself and the students and the parents. And after like the session, like we'll just go over any of like signs and symptoms that we saw, and then just kind of talk it out, honestly.
There's also like additional teaching opportunities too. So we have a pediatric feeding workshop. That's an interdisciplinary workshop with another smaller school here that has an OT program. And so we're going on the second year of offering that. And so they're getting experience outside of the clinic to hopefully kind of boost up just the background knowledge. And it's also one of those times where, you know, ASHA requires like a 25% supervision rate. And so for general speech and language and stuff like that, of course, you know, we're always doing, I feel like, way more than that time. But there are definitely times where I'm like, I can be in the observation room and I can be laying eyes and kind of, you know, checking in and out or something on that patient. But like with our feeding, Briana and I are there in the room 100%. We're doing a lot more hands-on, a lot more modeling of the strategies. Because, you know, we could have students assigned to us in the fall with a PFD case who haven't had the dysphagia course with Briana yet. So they're kind of putting, you know, the practical side of things into place with us before they even get some of the background knowledge, which doesn't always happen that way. But there are some times where clinic doesn't line up with what coursework they've had just yet. So there is a lot more hands-on teaching opportunities than just your typical language speech kiddo when it comes to the feeding kiddos. So I feel like that helps with that, you know, kind of bridging the gap between class and real life and making sure that quality of care isn't impacted because our students are still learning in that area specifically.
Yes, but those are, so folks behind the scenes, there's requirements that supervisors have to meet. So one, go become a clinical supervisor because we desperately need you. But on the faculty side, you have to show and document how you're doing those leveling activities. And so creating the opportunities for those crucial conversations, pre-brief, debrief, doing an interprofessional education conference with another discipline, that's fantastic because, God, if every future SLP had an opportunity to walk a day in an OT's shoes like that, we might have less LPs and more OTs. So maybe not a full day, but like, it broadens your horizons, and we need that because we need our team members. But it's more than just like the bare minimum. Like, you know, yes, you have to do this leveling, but like you're taking care of a life and making it meaningful. That's so impactful.
Yeah. And I think the classwork is really great because like I said, when I was here, our dysphagia course was all adult focused. I mean, it was an excellent course, but there wasn't that pediatric side of things. And this is our only class that is co-taught with an academic and clinical faculty members. And I think that's so wonderful. And because our swallowing, our adult swallowing and our pediatric feeding caseloads, they're not huge. And, we have a large student population. And so not every student is going to get the hands-on with swallowing and feeding before they go to off-campus placements. And of course, once they're off campus, they're in hospitals, they're getting, their competencies and requirements that way. But just to have them have that foundation and to be prepped for those off-campus placements, I think the course is such a nice way to do that, because Briana and Angie teaching are so practical. They're really giving you the information. How many times did you sit in a grad school course and think, okay, but the semester's ending and we never got to treatment? Like, I feel like I sat in so many courses where I was like, why is treatment always last? Why is it always last?
It's because they didn't know. And that sounds horrible. But honestly, some faculty just researched and never treated, which is great that we understand the theory and the baseline. But what am I supposed to do on Tuesday at 3:00 in the afternoon when I'm looking at it? Right? Like,
what does the session plan look like? Yeah.
Exactly. What's your plan? So even those who didn't get to directly work with, either again, a little bit with me or Briana, they're still leaving with, I feel like, a way better foundation in pediatric feeding than I ever had, because at least we're touching on the basics, and they can go out and have some of that conversation with an off-campus placement or a future mentor or something, to where they're getting their toes wet, and then there's still so many ways where Briana and I have talked about, like, how we want to continue to expand. And, I think we're both done with the babies. And so the maternity leaves and all that. So we now
have a close shop.
We're.
I got my manicure last weekend, and the guy that was doing my fingernails, he goes, "So you're going to try for a girl?" I was like, "Darling, my children are 10 and 12. That ship has sailed." I mean, I'm not going into like the total, like, I had a total hysterectomy conversation with this strange man, but like, also, why would I feel compelled to do this again? And it's not any of your business. Like, right. My Southern accent comes out when I get mad about something, but yeah.
When we like chatted, we would chat last year, and I'm like, but you're going to go have that baby, and that's what you need to focus on. But when you come back and we're feeling settled and everything, like, then we'll continue to think, grow and expand. But right now, let's just go have that baby, have the baby. That's the most important. But we've talked about, Briana had a great idea for support groups for our parents. We have a lot of support groups for other disciplines, but we were like, this would be a great area to expand that support group in. We've talked about like a transitioning to solids just for the community, as a community outreach, and having our students involved all along the way for those additional teaching opportunities of, let's just talk to some families about how to help their kiddos transition to solids, and maybe, bypass the whole, I'm having a hard time, I need feeding at 2 years old. I know Briana is really interested in doing more lactation consulting and getting additional, additional certifications in that, because we haven't served a ton of babies so far in the clinic. And so there's so many ways that we want to continue to educate the students and continue to grow the program, that we just have to, take it one step at a time. But we have the thoughts, and I'm really excited to see where it all continues to go as we work together with everything.
Okay, so thought, if you're going to do the transition to solids, tying in with WIC, tying in with the WIC office, because they have to go in for their like check-in appointments, but like going and meeting with them, that would be so cool, because you're already working with an at-risk population. And that, to me, I could see that. If we borrow that idea for Augusta County, I am giving you 2 credit, because that would be cool to do here. But, and then for trialing, do y'all do any systematic like trainings for treatment? Like, do you pull in SOS? Do you talk about food chaining? Are you using the Rava's Savories crackers for transitional chews to teach that? Like, what does that look like?
Yeah. So in I cover a little bit about all of that in the treatment part. I mostly focus on like the Britt Pados research on like flow rates for infant feeding on the treatment and the impacts of that. And then I go into SOS and the food training as well. And I just cover like what they're about in the dysphagia class, but then within like the students in like my weekly group meetings, like we openly discuss like how can we food chain, and I'll give them like a case study of, okay, this is this patient, this is their food repertoire, these are the family goals of and the dietitian goals of where they would need this kid to be, and then we just talk about like, okay, how can we take this preferred safe food and then food chain it? We're doing it in clinic as well. And so the students, they have to submit session plans. And so part of what they need to do for the session plan is think about that and write it out to me. And then I give them feedback as part of that. And then I also, for those like weekly group meetings, just cover all those like extra certification trainings that they can have, with the premise of you don't have to take these certifications in order to do pediatric feeding, but if you want to, or if your employer is willing to pay, these are the ones that you can take.
Yeah. I see that they're like, oh, if you want to do feeding therapy, you have to be certified to be this. And I'm like, no, that's marketing, sweetie. Like you don't, I get younger grads that will call and they're like, well, I saw this. And I'm like, no. That's marketing. And that's, yeah. So I really appreciate that you go there.
And then I want to talk a little bit more too about that interprofessional pediatric feeding workshop that we do. So part of what we do there as well. So we have our students, the Tennessee Wesleyan occupational therapy students, registered dietitian, nutritionist students. And then this year, we're also going to have Rhone State's occupational therapy assistant students. And we all get them in like pre-assigned groups. And we have a guest panel of parents with children with pediatric feeding disorders, and then professionals in our area that are working in PFD. And so they get to ask them open-ended questions of what it's like to have a child with PFD, and get to see that piece of what that mental load could be like when we make recommendations for them to carry over at home, and get some insight on that day-to-day from a parent's perspective, because really that parent is the most important piece of that interprofessional team. So getting to hear it directly from a parent, I find it's super useful for the students just to be more aware of some of the coaching that they might provide and some of the trauma that can come with having a child with PFD. And then from the professionals aspect, it's just nice to have professionals out in the field that are doing it as well, say what their therapeutic practices are like and how their feeding sessions look like. Because, they'll also talk about like, today we practiced putting yogurt on our face and pretending it was sunscreen. And it's not just Briana that is doing crazy stuff like that.
I'm trying to explain this to parents. Like I have one family, I'm like, we really like construction trucks. You can eat with the bulldozer. And, they look at me and I'm like, no, it's a giant shovel. Like, look, just like, and then compromised and found bulldozer silverware. It looks like, I was like, that's the greatest invention ever. Guess who's eating with bulldozer silverware? Tuesday morning. But, I'm like, you just need the right tool. I can hear my husband when I try. I like to think I can hang things in the house. It doesn't go so well. There's normally 4 holes behind before he comes, and he goes, baby, just get the right tool. That's what feeding therapy is like. Get the right tool.
Mm-hmm.
Yeah.
Know the patient, know what their interests are. And then once you know that, you could really start to include that and be silly with the kid and figure out, they like Baby Shark. Maybe we'll do a Baby Shark song with this food, or pretend it's a shark and get imaginative with it. Yeah.
Do you have the caregivers in the room with you when you're doing feeding therapy?
Oh, yeah. Absolutely. And they are active participants in every session that way. And then I find it that's also useful too, because a lot of pediatric feeding therapy is the coaching aspect of it. And so with me, like being in the room with the students and the parents, with just verbalizing the why I'm doing some strategy and coaching the parent, the students are also hearing that as well and able to put those like strategies or information within like their therapy toolbox per se.
Yes. So you were talking about wanting to get the CLC. Are y'all pulling in the infants? Are y'all like getting nursing babies in there yet? Or are y'all like framework building this?
Framework building it at this point. I want to take the CLC class before like I move into that, just because I know I don't know everything about it. And just ethically for me, like I want to learn more before I start having those type of patients in the clinic. And that way I'm doing them justice, because I know there's just so much I don't know about that area just yet, even though I breastfeed my own babies.
I know I had the exact same thought process, because I was like, I do feeding therapy and I nurse 2 boys, but I wanted to get the CLC before I started working with it clinically, because I felt like that was just like you said, an ethical component. Like I knew enough to be dangerous, but not enough to be effective.
Yes. And like recently we had a 2-month-old and come into our clinic with laryngomalacia, and mom wanted to breastfeed, and she had been to multiple IV CLCs, but she was pumping, she was an overproducer. And like, she particularly asked me like, what about breastfeeding? And I was like, you could go to the IV CLC. Like, I know where, like for that, like I can help you with the bottle feeding right now. And like, she was, was seen a couple times and was good to go. But I think it was important for the students to see me put that boundary. Like, I know I don't have the knowledge right now to help you effectively. And so I'm going to refer you elsewhere, because I know my current boundaries and where my scope of practice is in this particular moment with my current certifications.
Yes, but you modeled that. And that is huge, because so many people don't necessarily put a stopgap for the line where they should. So like, thank you for being you. Like that's
we get referrals in, and I feel like we have to do that anyway. Like I have to go, because I coordinate our referrals, and I'll get one and I'll be like, Briana, I'm reading over this one. This is feeling like your territory. Because if it's a little bit, if it's more medical and that kind of thing, like I want to make sure and have that boundary too, of not just like, well, I'm just taking them because I have the room and Briana doesn't, or whatever. We really try to, we definitely cross over and stuff as needed, but I want to make sure that I tell my students, I'm like, I really try to stay in the sensory lane and neurodivergent lane, and I want to let Briana take medical needs and all of those other things, because that is her wheelhouse and what she's here to do. And so they even know between the 2 of us that like our feeding caseloads are not going to look the same, and that's okay.
Yes, but then you modeled intraprofessional practice, which is an aspect that we don't always do, because you can be a NICU therapist, you can be an EI therapist, but you'll have the EI therapist that's great at language versus the one that wants to do the little bitties versus the older toddlers. Like there's these finer nuances that we can grow into, but knowing the person to refer to and modeling that for the next generation, that's huge. Yeah. Do y'all have, so where are y'all sending them? Like if you don't have an opening or you can't get to them, how is the PFD community in your immediate area? Oh, it's like everywhere else. Yay! Okay, folks that couldn't see that was a whole lot of never really know.
Oh yeah, that's a struggle. I definitely think that can be a struggle around here. I mean, we have a great children's hospital. So, if we're looking for any kind of instrumental studies, we definitely have a great place and connection there to refer to. for other therapy, I don't know. With Briana being on maternity leave, I basically told our early intervention service, like, hey, our primary feeding person's out. We're not going to be able to do new feeding evals for this period of time. And that was kind of it. And so I honestly don't have an idea of where those referrals may have gone. I do feel like right now our caseload, as it's building back when Briana comes back, is mostly in-house. It's mostly a lot of our kids, like I said, who are already being seen for speech, who have feeding concerns, and that we're, expanding into like a second session during the week. Unfortunately, we do get some referrals that are, my kid was force fed or dismissed from feeding therapy because they weren't ready for feeding therapy, which they were just so adamant about not wanting to touch or interact with anything, which to me tells me they absolutely need feeding therapy. So I think we kind of get the other side of it where we're like the second feeding therapist because they've been turned away from other places, which is hard. So it makes it hard to know where to refer out because unfortunately we and I know that there's great things going on that we just typically hear the bad news, not the good news. Because that's the stories that we get from some of our families. And it's just heartbreaking to have a kid who has only taking pouches and won't have anything to do with any solids and they're not ready for feeding therapy. I very disagree with that.
I have and before
go ahead. Sorry, go ahead.
Oh, sorry. Like before too, when like we've come or had like a referral come in for like a patient like that, maybe I felt like was outside of my wheelhouse or the parent was looking for something very specific. Like I've called around to just find an appropriate therapist for a family before and then referred them to that person when I did find somebody that was appropriate within our community. So I'll try to do that as well at times.
Feeding Matters has a directory. That's the word that I'm looking for.
Yeah.
So I'll have them like, especially if they're coming in from like a really big distance, I'll try, hey, check out the directory, see if that's an option. One of the things I've had to focus on mentoring with grad students is when they're not medically ready. Like it's not like there's a nuance, like when we're not medically stable.
Sure.
Because I have one little guy on my caseload right now who we're having to do frequent enemas just to get stool out, like at a hospital because we can't do them at home. And I'm like, okay, so you just need to accept what we can because we're like looking at major surgeries. And I'm like, it is a caloric intake goal right now. So everybody on the team is like, just put in what we can put in. And then once we're healed and can stool without a horrible traumatic experience, then let's come back and try to expand and try challenging foods. But I mean, and I feel like my definition of putting on hold for medical has evolved as I've learned. Do you guys see that too? Like what you would have done? Yeah.
We have put some families on hold from feeding therapy for like similar reasons where like there's just so much medically going on right now that you need to figure that out and put all your brain power to going to those medical professionals to really figure out get to the bottom of what's going on medically before like you come back and may focus on like expanding your food repertoire. Because you never know what that underlying issue may or may not be. And you might be causing more harm if you're trying to focus on a food that might not be what that particular patient needs.
Yes. I did that. I had a little guy years ago who mom really wanted him to eat green beans of all things. And I know you're not, but like really wanted us to eat green beans. And so every week he would touch it, play with it. He would bring it and smell it, but he would not put it in his mouth. We had EOE and one of his allergens was green beans, but he knew, knew. And I look back on it and I'm like, how did I not see it, but also give yourself grace for how we practiced and then evolved. We have covered 400 different things in this board. And I love that so much. What have we not covered that you want people to know? Because this is you guys are doing such great work. And this was the fast. I have recorded 4 sessions in the last 24 hours. And this was by far the fastest. Like it just went.
Yeah. I was looking at the clock. I'm like, oh, we've already been on for like over an hour.
Yeah. But like, what do you wish people knew about setting it up at a university clinic, or like the meaningful connections with the students?
I mean, I think if you're not teaching it, then like where are they learning it? But then what kind of therapist are we sending out there? You know, because they're a reflection of the programs that they're going through. And so I can sit back and say, you know, my students had a solid experience with neurodiversity. My students know EI. My students are going to be great therapists in the areas that I know that I taught them well. So if you're a passionate teacher and this is an area that you're interested in, you know, start growing your knowledge, because it was definitely like newer for me just a couple years ago. And I'm again still learning, but I think that, you know, with Briana's support, like we're laying such a great foundation for our students, and we can feel confident saying they had that good experience to start their career because we taught them. Because if we don't teach them, who is?
Yeah.
Yes.
And I would have to say, like, don't be so afraid of failing that you don't try. I wouldn't be here today if I didn't take those risks, and I am so much better for it. Like, I've learned so much just coming here and just getting my feet wet in the academia world. And if you're considering like starting a pediatric feeding clinic in a university, just seek out a mentor, start taking the CEUs and see what comes of it.
Yeah.
It doesn't have to be perfect. We all start out as beginners. So
yeah. And if you know your boundaries, then, you know, you know when to accept a referral or when to refer out. You know, you don't have to accept just to accept. So like if it's not in your wheelhouse, you know, find them someone who is. That's a good, like we said, that's a good model to set for students too, is you don't have to grow by taking everything all at once.
Yeah. It's a good philosophy for life. Yeah. Yeah.
We're philosophical this morning.
I was ready to say, somebody had really good coffee in Tennessee. I'm on my 3rd cup of blackberry spiced tea.
sounds good.
And 3rd teacup, but you know, que sera. This was phenomenal. You guys take the opportunity if you can, reach out. Can y'all share your email addresses so that folks can reach out to you? Is that okay?
Yeah, sure. Yeah. Do you want me to just say them? Like say our,
yeah, okay. How do we do that?
Mine's MWilly. It's MWILLI86 at uthsc.edu.
And then mine is bgaines6 at uthsc.edu. And Gaines is spelled Gaines. It's my maiden name.
I was ready to say that's not your name.
That's not my name.
If you were ever a student, you're stuck with the name that you had when you were here. So we were both unmarried as students. So that is still our faculty email, which is so confusing.
If somebody is listening and they want to make a donation, where can they donate to honor your time today?
So we can link our giving page for the university, but we have a drop-down menu, and it includes all kinds of support groups, endowments, scholarship funds. So it's not necessarily just going, you know, straight into the university, but going to specific places where we're doing outreach in our community. So you can really, you know, donate to anything that really pulls in your direction. We have a lot of really awesome faculty doing really cool things. So there's a million choices on there for places you could give.
Yes. Okay. So folks, be sure to stay tuned for the Saul Adler on March 27th, and it's AAC. And that's phenomenal. Ladies, thank you so very much for doing the hard work that you're doing and for coming on today to share it. So thank you.